and welcome to the Alabama Public Health Training Network. Thank you for joining us for our program today, Demystifying Systemic Lupus Erythematosus. If you have questions about anything being discussed today, please call or email during our broadcast. The phone number and email address are on the screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluations are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses, social workers, and physicians for today's program. CME credit for physicians is only available if today's program is viewed live and will not be offered for on-demand viewing. If you're seeking CMEs, you are required to complete the pre-assessment and post-assessment for this program. If you've not completed the pre-assessment, do so now. You can find the pre-assessment by visiting the alabamapublichealth.gov/ALPHTN. The post-assessment will be posted on the same website. You must complete the post-assessment by 5 p.m. today to be eligible to receive CMEs. Once you have submitted the assessment, you will be provided a link to the Lupus Initiative's website. There, you will follow the instructions to claim your CMEs. CMEs must be claimed within 1 year of participation. Continuing education credits for nurses and social workers is approved for both live and on-demand viewing. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credits will only be awarded for 1 year for nurses, expiring on May 31st of 2019, and 2 years for social workers, expiring on May 31st, 2020. No relevant financial relationships have been identified for CME planning members or speakers for today's program. Let's get started. Dr. Amanda Schnell is the Rheumatology Fellow at the University of Alabama, Birmingham. Dr. Schnell?
Hi there. So today we'll be talking about demystifying systemic lupus erythematosus. And again, I'm from the University of Alabama at Birmingham. So welcome. We're excited to speak with you today about lupus. Before we get started, this program is brought to you in part by the American College of Rheumatology, and this is designated as a AMA PRA Credit 1 for physicians. Like with any presentation, this activity with the educational links is to be used as a learning tool, and that is why we're doing the pre and post test today. Drugs and doses. When prescribing medications, we advise physicians to check the product information sheet accompanying each drug to verify conditions of use and to identify any changes in drug dosage schedule of contraindications. And then again, the American College of Rheumatology is an independent professional organization that does not endorse specific procedures or products. This is part of a grant, and there are no disclosures today. Again, the pre and post assessment is voluntary. It's used solely to rate the quality of this seminar. No individual data will be shared as part of this project, and we use the unique identifiers only to match the assessments for analysis. Final data will be reported in aggregate form. So again, the pre-assessment should be done before the seminar, so if you haven't done it, try to answer the questions now. There are 10 multiple choice or true and false questions, and 1 efficacy question, and there are some additional demographic questions as well. The post-assessment is done after the seminar. It is a repeat of the pre-assessment, and there are a few additional qualitative questions. Follow-up, there's a follow-up assessment in 4 to 7 weeks after the seminar. It's a repeat of the pre-assessment. There's options for comments, and it does require an email address that is completed on the sign-in sheet. And again, it is voluntary. So again, we thank you and appreciate your time in taking the pre-seminar assessment. If you can complete the unique identifier as listed on the screen, and write your name legibly so they can match and use the data. That would be greatly appreciated. So the learning objectives today. After this presentation, you should be able to recognize the signs and symptoms of lupus, know when to effectively refer a suspected lupus case to a rheumatologist, know how to initiate a workup for lupus, and finally have increased knowledge about lupus, epidemiology, health disparities, and disease characteristics. So we've all heard the expression, when you hear hoofbeats, think horses, not zebras. But in many cases, lupus is a zebra. With a worldwide prevalence of 140 out of 100,000, lupus is likely not the reason the woman in your office has a fever and fatigue. However, if you are seeing a patient of color, especially a woman in her childbearing years, that unexplained prolonged fever has a greater likelihood of being one indicator of lupus. So lupus affects up to 1 in 250 young African American women in the United States. And it is also more prevalent among Hispanic, Latino, Asian, and Native American women. Lupus has a prevalence of about 90 cases per 100,000 in Hispanics, Latinos, and about 143 per 100,000 in Hispanic and Latino women. So again, when the person you are treating is a person of color in her childbearing years, lupus is not a zebra, it's a horse. So meet Ivana and Michelle, two of our video participants here.
My name is Ivana Ford-Neal, and I was diagnosed with lupus at 16.
My name is Michelle Stevens, her sister, older sister. I was diagnosed with lupus at 22.
So a lupus diagnosis can take as long as 2 or more years and include visits to 3 or more healthcare providers. So why is the diagnosis of lupus so challenging? Lupus is the great masquerader. It can mimic other conditions like viral syndromes, malignancies, allergic reactions, and stress. And sometimes it is associated with depression or fibromyalgia, which can also confuse the picture. Why is the diagnosis of lupus so challenging? Again, symptoms may be vague, and they may include fatigue, achiness, stiffness, low-grade fever, swollen lymph nodes, and rashes. Symptoms may develop slowly, they may come on suddenly, and here are the two describing some of the difficulty of being accurately diagnosed.
There was a long delay in my diagnosis. I had doctors try to burn my face, burn the scars off. I had doctors that would just tell me, oh, it'll go away. It was almost a year before I was truly diagnosed with lupus, and kind of scary at the same time because didn't know what was going on with my body. And so it took, I think I've seen close to 15 to 20 doctors, and none of them diagnosed me with lupus. It was always something else. One thought it was the water I drank in Colorado. Another thought it was genetics because I was African American. Another just said, oh, it's just probably something you ate and it'll go away. And then another said, it's just growing, just something you go through when you're growing.
So the delay in diagnosis can be devastating for a person with lupus. It could lead to organ failure, and these patients can have a 5-fold increase in risk of death. But with an early diagnosis, the chances of a person with lupus living a full life with a manageable chronic disease is increased. Unfortunately, specific racial and ethnic minorities with lupus have mortality rates that are at least 3 times as high as white individuals. And often, because they are poor and they do not have access to primary care doctors and specialists who can diagnose and treat them. A person who is feeling sick will often seek help from a primary care provider or emergency room at the onset of their symptoms. So it is crucial that these providers recognize the potential symptoms of lupus and make referrals to rheumatologists when appropriate. Unfortunately, the amount of training providers receive in medical school varies widely, with some students only receiving 90 minutes of education on lupus. So it is our mission to educate primary care providers about lupus, so patients with lupus can get the correct referral, diagnosis, and treatment they need.
I was diagnosed at 22 when I was pregnant with my son. Well, pregnant with my son, and I ended up having a miscarriage, and that's how they found out that I had lupus. And I can tell you the change that it had in my life, just it ached and it hurt because I saw how my sister was going through changes, and for me it was very hard because I knew that it would be happening to me next. So it was very, very hard.
So let's review some of the symptoms and challenges related to the diagnosis of lupus. So lupus is an inflammatory, multi-system autoimmune disease of unknown etiology with clinical manifestations that can change frequently and unexpectedly, and there's also some suggestive laboratory manifestations as well. So lupus is challenging because it can be mild, severe, and anything in between. The diversity of the clinical symptoms is great, and all organ systems can be involved. Lupus is characterized by periods of flare and remission and can culminate in irreversible end-stage organ damage. So the pathogenesis of lupus. Autoimmunity is an altered immune homeostasis that leads to autoreactivity, immunodeficiency, and malignancy, which you can see on the flowchart on the right. Immune dysregulation, leading to autoreactivity and autoantibodies in lupus, occurs in different phases and likely represents effects of the environmental triggers on the genetically susceptible host. So let's take a look at some of the symptoms. When looking for skin conditions, keep in mind that these skin conditions look different on diverse skin tones. So first is synovitis, or swelling of joints. Second is the classic butterfly or malar rash seen on the face that spares the nasolabial folds. Third is painless oral ulcer that typically occurs on the hard palate. And next is Raynaud's phenomenon. We have discoid rash, also called discoid lupus, Jacquard's arthropathy, which involves the tendons of the hands typically, vasculitis lesions that you can see on the skin, and alopecia. Lupus symptoms can make diagnosis difficult because they can be indicators of many conditions. These symptoms include achiness and headache, fatigue, memory thief or brain fog, and depression. Some of the organs impacted by lupus can include the lining of the lungs and heart with serositis, and pericardial effusion, cerebral infarct or stroke, brain atrophy, spherocytosis, and glomerulonephritis in the kidney. So many organ systems involved. When to suspect lupus? Think about lupus if a patient has oral ulcers, especially those painless oral ulcers on the hard palate. If they have a malar rash, discoid lesions, or are photosensitive out in the sun. If they have arthritis or myositis with muscle weakness. Again, if they have serositis or inflammation of the lining of the lungs and heart. A low blood count or anemia. If they have protein or blood in their urine. Or if they present with seizures and psychosis with these other symptoms. And then finally, if they have positive laboratory values for ANA, along with some of these other symptoms. So you can see there's lots of signs and symptoms of lupus, and the most common ones are at the top with arthralgias, neurologic symptoms. Many patients present with fever. And again, fatigue is high on that list as well. So Michelle and Ivana are sisters, but again, they have different symptoms, with Ivana's being more external with her skin rash, and Michelle's being more internal. And here they describe their respective symptoms again.
One of the first symptoms of lupus that I had without knowing it was lupus was the swelling in the middle of my forehead, and then the body aches, where at one time they didn't think I would be able to finish school or even be alive. And it went from there, where the butterfly pattern on my face, and then more of the spots just really on my face at first. Then after that, I had the hair loss. I woke up one morning and I had no hair. And then I got the really bad joint pains, fatigue, depression, suicidal thoughts that come with the depression from the illness. It's not just a physical, it's an emotional downdrop. I've also had the tooth loss, the scaling of the skin in the ears, on the legs, just about everything you can imagine with lupus I've had, except I've been blessed for it not to have affected my internal organs, unlike my sister, which she forgot. I had a problem with her kidneys. I have kidney disease now. It started attacking my kidneys, where I'm losing a lot of protein. Protein's in the body, but it's not doing anything, and it's still going out. I also had a lot of depression, suicide thoughts, cried, didn't understand why God let this happen to me.
Unfortunately, there's no gold standard diagnostic test for lupus. But the most common screen for lupus is the ANA, also called or known as anti-nuclear antibodies. So the vast majority of women with lupus test positive for ANA. But a positive ANA test does not mean the person has lupus. ANA could also indicate scleroderma, Hashimoto's thyroiditis, idiopathic pulmonary fibrosis, and it is also present in other chronic conditions, like chronic infections. So what do most lupus patients have in common? That is the ANA, or the anti-nuclear antibodies. ANA, or anti-nuclear antibodies, are autoantibodies against various components of the cell nucleus. They are present in, again, as we said, autoimmune illnesses, several infections, malignancies, and can occur in healthy people as well. And the key point is that they are sensitive, but not specific for lupus. Because of the low specificity, ANA usefulness increases if the pretest probability for lupus is high. So if you think a patient has symptoms and signs of lupus, it is more likely that your ANA is positive and that they have lupus. Again, because of the high sensitivity of the ANA, a patient with a negative ANA is unlikely to have lupus, even when her or his clinical presentation is suggestive of lupus. So if you have a patient that you suspect has lupus, think about ordering the following tests. First is a CBC with differential, a urine analysis, and a renal function panel. Think about ordering a urine protein to creatinine ratio if there's any protein seen on the urine analysis. And again, the anti-nuclear antibody is positive in a vast majority of patients with lupus, but again, be aware of false positives. The higher the titer is more likely to be clinically significant. So if there is a titer of 1 to 1280, that is more clinically significant than a titer of 1 to 80. If the ANA is positive and the patient has symptoms of lupus, consider additional autoantibodies. And these additional autoantibodies are the anti-double-stranded DNA and or the anti-Smith, which is more specific but less sensitive for lupus. Next, think about ordering complements, C3 and C4. So they're often, but not always, low in active disease. Also think about ordering acute phase reactants, such as the SUD-rate, or the ESR, and C-reactive protein, or the CRP. They're elevated in other causes of inflammation, like infection as well. So here is a chart of the autoantibodies in lupus. And again, at the top of the chart, we have the ANA, which again, as we said, was low specificity but high sensitivity, meaning it is nonspecific. The next autoantibody is the anti-double-stranded DNA. It is highly specific, not as sensitive, and it is associated with nephritis. The anti-Smith, as we said, again, was highly specific, but not as sensitive. Other antibodies in lupus can include the anti-RNP, which again is not specific, but can be associated in lupus with arthritis, myositis, and lung disease. And then we have the anti-SSA and SSB antibodies. They are not specific, but they are associated with dry eyes and dry mouth. They're associated with subacute cutaneous lupus. And they're also associated with neonatal lupus and photosensitivity. So it is important to check these labs in a patient you suspect that has lupus. And likely rheumatologists will do that after the patient is referred. The last autoantibody on the chart are antiphospholipid antibodies. They have intermediate specificity and sensitivity, but they're associated with clotting disorders. Probably like in our patient's case that had the miscarriage. So how do you determine whether or not to order an ANA? If you think an autoimmune rheumatic disease is likely, again, the ANA can be helpful for diagnosis and classification. If you feel like the autoimmune rheumatic disease is unlikely, do not order an ANA. A positive ANA may cause anxiety, unnecessary investigations, and potential confusion for both patients and providers. So labs to consider in patients with non-specific symptoms and a low probability of lupus. Look for evidence of kidney disease. Order a urine analysis, a urine protein creatinine ratio, and these can be done conveniently on random spot urines. And that can also be done in a patient that you suspect lupus. We usually use a spot urine instead of doing a 24-hour urine, as many patients don't complete the whole 24 hours. And again, these are also things to look for in patients with a probability of lupus as well. Looking for hemolytic anemia, thrombocytopenia, lymphopenia, and neutropenia. And that can be done with a CBC with differential white count. And we commonly see hemolytic anemia, thrombocytopenia, and lymphopenia in our lupus patients. Looking for renal function, acidosis, liver disease, and muscle inflammation. These can often, but not always, be low in active disease. And then again, the acute phase reactants, they can be elevated in other causes of inflammation as well, like infection. A lab to consider in a patient with nonspecific symptoms, especially fatigue, and a low probability of lupus would include the TSH. So many patients that have fatigue, including our lupus patients, could have other various symptoms, but hypo and hyperthyroidism are very common and may present with fatigue. And again, look for effects of lupus and not just autoimmunity. Ask about possible thrombosis, like DVT or pulmonary embolism, as well as miscarriage history, thinking about possible antiphospholipid syndrome. So again, when the person you're treating has symptoms of lupus and has a positive ANA test, it's important to refer them to a rheumatologist, especially if that person is a woman of color in her childbearing years, because at that time, lupus is not a zebra, it's a horse. So the epidemiology of lupus, so the prevalence is 2 to 140 out of 100,000 patients or people worldwide, but it can be as high as about 200 out of 100,000. And the incidence ranges from 1 to 10 in 100,000. Women are 9 times more likely to develop lupus than men, which you can see from our pictorial representation on the screen. Lupus affects mainly women in their reproductive years. And African American, Hispanic, Latino, Asian, and Native American women have the highest prevalence. In fact, lupus affects up to 1 in 250 African American women in the United States. People with lower incomes are less likely to receive recommended care, and poverty is associated with poor outcomes. Again, African American women have 2 to 3 times higher risk of lupus than white women. And African American and Hispanic Latino women with lupus have mortality rates that are at least 3 times as high as white women with lupus. African American and Hispanic Latino women are more likely to develop lupus at a younger age and have more severe symptoms at onset. So here's a video about one of the rheumatologists about diagnosing lupus and the disparities that are present.
I'm David Wapsie. I'm a professor of medicine at the University of California in San Francisco, and I've devoted my research career to the development of new treatments for people with lupus. The stark reality in health and health care in the United States is the disparity that exists between different segments of the population. This disparity applies across a broad spectrum of conditions, but it is especially striking in lupus. Lupus disproportionately affects women. It is more common and more severe in minority populations, and it tends to be more prevalent in people who are poor. Many factors contribute to the disparate health outcomes, including the actual biology of the disease itself and factors in the environment. For example, the genes that predispose to lupus appear to be different in minority populations, which may account for some of the differences in disease severity. And the drugs that are commonly used to treat lupus appear to work less well in people of color. However, there can be no doubt that the healthcare system contributes substantially to health disparities. Poor access to care, lack of health insurance, delays in diagnosis, and low quality of care are all problems faced by people with lupus. Taken together, all of these factors pose a real challenge for people with lupus, and a real challenge for anyone who seeks to end health disparities in this disease.
Lupus and mortality. Cardiovascular disease is the major cause of death in people with long-standing lupus, and that is a key point. Factors contributing to the increased mortality include active lupus and infection, high disease severity at time of diagnosis, younger age at diagnosis, meaning they'll likely have lupus for a longer period of time, African American and Hispanic, Latino, Asian, and Native American ethnicity, male gender, low socioeconomic status, poor adherence to treatment protocols, an inadequate support system, limited education. And a key point in this last slide is with the poor adherence to treatment protocol and compliance with making appointments. They found that that is very key in keeping these patients adequately controlled of their disease. So importance of early referral. As we saw with the mortality, mortality is higher in people with lupus compared to the general population. The 5-year survival rate in 1953 was 50%. Today, the survival rate is 90% because of better detection and treatments available. Currently, 80 to 90% of people with lupus survive 10 years after diagnosis, but unfortunately, that drops to 70% with the advanced stages of organ deterioration. And again, the leading causes of mortality are preventable with the appropriate therapies available. So let's look at a couple case studies. First, we have a 23-year-old Hispanic Latina woman with no past medical history who presents to emergency department with the following symptoms. She has an 8-week history of joint pain and swelling in her hands, knees, and ankles. She has a fever. She has myalgias or some muscle pain. She has pleuritic chest pain, weight loss, and she reports a facial rash that worsened with sun exposure. She initially went to a local clinic and was treated for cellulitis with oral Keflex. 2 days before she presents to you, she went to another emergency department. At that time, she had a temperature of 103 degrees Fahrenheit and reported anemia. She was told at that time that she had a, quote, viral syndrome and was discharged. So on her exam, her temperature when you see her is 37.9 degrees Celsius. She has a painless ulceration on her hard palate. Her blood pressure is 130/90. She has a malar rash on her face, diffuse lymphadenopathy, and has synovitis or swelling of the MCPs and PIP joints of her hands. Her labs, which have been accumulated from various providers over time, she has a white blood cell count of 2.5, a total protein of 9, with an albumin of 3, which is low in someone her age, a hemoglobin of 11, with a hematocrit of 32%. She also has a BUN of 11 and a creatinine of 0.7. On her urine analysis, she has 100 milligrams per deciliter of protein. She has red blood cells present, also in that urine analysis, and has some positive autoantibodies, including a positive ANA, a positive double-stranded DNA, and a positive Smith antibody. So, this is probably an easy question by now in this presentation, but should this person be referred to a rheumatologist? And I'll let you think for a second. But the answer is yes. This person should be referred to a rheumatologist. She has many signs and symptoms of lupus, as well as the positive autoantibodies, which are the features in this case that are concerning for lupus. She's also in the right age group and demographic to have lupus. And as you can see, this patient's care was fragmented. She was at a clinic and several different emergency rooms, which is often how these patients present. So let's look at another case study. And this one's a little bit different. So in this case, a woman from Western Africa was recently diagnosed with anemia, and it's presumed to not be, it's not confirmed, but she's presumed to have iron deficiency. And she comes in to her doctor with the following symptoms. She has swelling of her feet and hands. She has a non-specific rash on her face and arms. She has swelling in the joints. She has enlarged lymph nodes. She complains of generalized body aches. And she reports sweating. Her chart review reveals a positive ANA of 1 to 1280, which you remember from before is a high titer ANA. She has a white blood cell count of 4.2 with a normal differential. Her hemoglobin is 9.7, so we confirm the anemia, with a hematocrit of 30 and an MCV of 77. And she has a platelet count of 307. So should this person be referred to a rheumatologist? Yes, she should. So what features in this case are concerning for lupus? So again, she is the right age and demographic. She had a positive ANA. She has anemia. And she also had many kind of non-specific symptoms, but combined, more concerning for lupus. So kind of as we demonstrated in these cases, attributing symptoms to lupus can be challenging and often requires first a certain level of suspicion. So in the right age and ethnicity and gender, think about these cases of lupus being horses and not zebras. It is really important to take a careful exam as well as history. Many of the signs and symptoms of lupus can be elicited from the history and exam. And these patients are often frustrated and they've seen various other healthcare providers about their lupus symptoms. So trying to tie these symptoms together with their exam and history is very important. So here's Ivana on the importance of listening.
Some of the good things that my physicians have done, it started with my primary care physician. And the first thing she did was listen. She sat in the room with me for an hour, and she just listened to me, start from the beginning to the point where I got to her. And she took every little thing that I said to heart. And she says, well, okay, if that didn't work, then we'll try this. And she says, well, she was more honest, I think, and looked deeper into me than I did myself. And she says, you know what? I really don't know what to do for you, so I'm sending you to Dr. Sack in San Francisco. And the one thing that I would say for anyone that decides to become a doctor and has to see someone with lupus is to listen. Don't think you know everything, because we all look different and we all have different symptoms. Some of us may have multiple symptoms in one, but to listen, listen, listen. Don't overshadow your patient. Just listen.
So in summary, early symptoms can be nonspecific and can be easily mistaken for other illnesses or syndromes. Symptoms may be transient or prolonged and independent of one another. Consider lupus if the person you are treating presents with vague complaints from the signs and symptoms list. Also, consider lupus if the person has a family history of autoimmune disease. Finally, do an initial screening, including a CBC, a basic metabolic panel, liver function tests, a SED rate, CRP, ANA, and urine analysis. And again, refer to a rheumatologist for assessment and diagnosis. So working together toward diagnosis is crucial. Building trust with the patient is very critical in this process. People from different cultural and socioeconomic backgrounds experience illness and treatment very differently. Physicians from different cultural and socioeconomic backgrounds also perceive the people they're treating and their symptoms differently. Through education, like this program, we can eliminate disparities in the time that it takes African American and Hispanic Latino women to get diagnosed and treated with lupus. So again, when the person you are treating is a woman of color in her childbearing years, lupus is not a zebra, it's a horse. And here's a call to action, again by Dr. Wolfsey.
The comments that you've just heard are really a call to action for all of us. The courage and honesty of the people who have spoken underscore the importance of developing better treatments for lupus and ending healthcare disparities in this condition.
So referral to rheumatology. Again, referring to a local rheumatologist is key if you think a patient has lupus. We are from the University of Alabama, Birmingham, and in the Birmingham area, if you'd like to refer a patient that has, you think has lupus, call the Rheumatology Scheduling Office at the number listed with the fax number. Resources and information. So ongoing care for people with lupus or patients with lupus is a team effort, but can be a matter of life and death. There are lots of resources like presentations, videos, and interactive case studies, and additional CME courses on the Lupus Initiative website. And it's listed at the website that is underlined in teal blue. The Lupus Initiative website is also a great place for patients to go and get more resources about lupus. So we really appreciate your participation in the post-assessment and in the 4 to 6 week follow-up assessment from this program. So again, thank you, and we'll take questions now at this time, if anyone has any.
This is your opportunity right now to call and email us with your questions. The number and email address are on the screen. I'm going to start with a couple questions that I have for you. So you talked about how women of childbearing age are the correct demographic. So could lupus cause infertility or miscarriages?
So lupus is associated with infertility and miscarriages, largely with the antiphospholipid antibodies, causing clotting disorder that could affect the placenta, that could be causing the miscarriages. And so if a patient has especially late-stage miscarriages, that is more of a concern.
So if these women do become pregnant and also suffer from lupus, will they have to stop taking lupus medications, or do you think that they may have to take medications during this pregnancy to prevent the clotting?
So, and many of our lupus patients are very different. There's a wide spectrum. We continue most of our lupus medications during pregnancy, especially the medication Plaquenil. Most of our patients are on that medication for life when they have lupus, and it actually helps prevent some of the blood from clotting. If a patient has a history of DVTs or thrombosis, they're likely on anticoagulation during their pregnancy. But if a patient has lupus, the most important thing is for the disease to be well controlled during pregnancy. And a lot of times in our patients with lupus, we talk about contraception and pregnancy planning, and have close discussions with the gynecologists in managing those patients to keep their disease well controlled while they're pregnant.
Awesome. We have a call from Birmingham. So caller, go ahead.
Hello.
Hello.
Can you hear me?
Yes.
Okay, I'm calling to ask about the prevalence of lupus, and why do you think that it is greater in African American women, Native American women, and Latino women versus Caucasian women?
So we don't know the answer to that, but we think it has to do with the interaction between genetics and environment.
Okay, so it's basically not known, but there's a possibility that genetic factors are involved.
Correct.
Thank you very much.
You're welcome.
Another question for you. So if you were speaking to someone who is diagnosed with lupus, are there lifestyle changes or maybe potentially diet changes that you might offer these persons to help manage some of their symptoms?
So not necessarily in treatment of their lupus, but in managing their symptoms, yes. We encourage all our patients to live healthy lifestyles with exercise as able and eating a healthy diet. Those things are all important. Also, sleep hygiene is very important in everyone, but especially in lupus patients, in trying to manage their fatigue. And a lot of times, screening for depression or other sleep disorders is important, because that can be a separate cause of fatigue in a lot of these patients as well.
Is lupus hereditary?
So we do think there is a genetic basis of lupus, sort of with that prevalence question. Patients, and they've done twin studies, someone that has a family member with lupus does seem to have a higher probability of having lupus.
How often should someone who has lupus go for a checkup? Should they increase their checkups or to help manage their disease?
Mm-hmm. So great question. A lot of that follow-up is determined by the activity of disease. So our patients that have more active disease are seen more frequently. Our patients that may be well managed with no current symptoms or their disease is well controlled can space out their follow-up a little bit longer. So it is very variable based on the activity and severity of their disease.
Okay, so I know you talked about the lupus signs and the symptoms, but would you say that what would you say, is the most common symptom to be expected during a flare-up, and what's the best way to prevent a flare-up if there is one?
So that's a great question and challenging to answer because every lupus patient has different symptoms that they present with for their flare-ups. Some patients may be more fatigued. Some may have the classic facial rash, like the malar rash. Some patients present with other types of rashes. Some patients present with joint swelling, fever, swollen lymph nodes. So there's a variety of symptoms. Many patients that flare in their disease do have the same symptoms when they flare, and so a lot of them can recognize those symptoms and be seen at an appropriate time.
Is there anything that may trigger lupus or make it worse?
So we don't know exactly what is a trigger for getting lupus. We think, again, the interplay between genetics and environment could play a role. Some patients do have some triggers for their flares, one of them being a lot of them are photosensitive, and so being out in the sun can be a trigger. Other times, other illnesses, infection can also trigger a lupus flare.
Can you tell us a little bit more about treatment options and any advancements in research that you may be aware of?
There's lots of advancements occurring daily. So our mainstay of treatment is the anti-malarial drugs, such as Plaquenil. And most of all, if not all of our patients, if they can tolerate these drugs, are on them. Other manifestations of lupus, if a patient has more severe disease, like disease affecting their kidneys or other vital organs, are put on medications such as mycophenolate or cyclophosphamide to treat inflammation secondary to the lupus in those organs. There's also new biologic medications available, and there's several trials that are ongoing, some at UAB that are trialing new methods of treatment and other biologic medications. So there's vast growth in the area of lupus, but we do stick to our mainstay of antimalarials as baseline.
What are the most common side effects of medications given to patients with lupus, and are there any medications that may trigger or aggravate lupus symptoms?
So great question. For example, with our antimalarial drugs, it is crucial that patients have eye exams yearly due to some of the side effects that occur in the eye. Those medications are very well tolerated, and usually patients don't have many side effects. As we get more advanced, some of the other side effects from the other drugs can include GI side effects, and every drug has different side effects, so difficult to generalize. Our medications that are immunosuppressive, such as the mycophenolate or the cyclophosphamide, can make patients more prone to have infections. And so it is important that we monitor those patients and they notify us if they have any signs or symptoms of infection.
Are lupus drugs only taken during a flare-up, or are these medications that the patient will take for the rest of their life?
Many of the medications are taken for life, especially the anti-malarial drugs. And lupus can be quiet or have low disease activity for quite some time, and then a patient may become more active, and vice versa. And so if there's more disease activity, and we measure that by some of the physical exam history, as well as laboratory manifestations, if the disease is more active, then we increase the immunosuppression, and we would add stronger immunosuppressants to that patient's drug regimen.
All right. Are there any supplements or natural products that a patient could take to help with their lupus?
So supplements and natural products are not approved by the FDA, and so we probably wouldn't comment on any of those.
We're getting close to wrapping up. Are there any key points that you might want to go back over just real quick just to help the doctors and nurses and social workers?
I think a key point is taking a good history and physical exam. And if your patient has signs or symptoms of the good history of that you think is concerning for lupus, checking those basic labs as well as an ANA can be useful. I think bewaring of false positives is also a key point. If you have an older patient that may have other comorbidities such as hypothyroidism, the likelihood of them having lupus would be less likely. So I think using good clinical judgment and referring to rheumatologists if you have a patient in the right age demographic with the signs, symptoms, and labs that seem concerning for lupus.
Well, thank you so much, Dr. Schnell, for sharing all your knowledge, and thank you for joining us. If you're seeking CMEs, please remember that you need to take the post-test that's located on our website. Have a great day.